I'm Andrew Alexis. I'm a dermatologist from Mount Sinai, St. Luke's, and Mount Sinai West in New York City, and I gave a presentation on updating the management of pigmentary disorders. When it comes to pigmentary disorders, there are two broad areas: hyperpigmentation and loss of pigmentation, including hypopigmentation. Between the two, hyperpigmentation is probably the most common scenario that we see clinically. And when it comes to managing hyperpigmentation, one of our go-to therapies, and has been for decades, is hydroquinone, especially hydroquinone 4% in various formulations. Now, a lot of questions come up with use of hydroquinone because, as effective and safe as it may be, we also know that excessive use, long-term use of hydroquinone has been associated with the adverse event exogenous ochronosis, which is extremely difficult to treat when it occurs. So as far as strategies to minimize the risk of exogenous ochronosis, the duration of time of therapy with hydroquinone is very important. So what I like to emphasize is that based on data and experience, 6 months would be considered a safe period of time for continuous use of hydroquinone. So in my practice, I'll typically use that as a benchmark, treat patients with a long-term pigmentary disorder like melasma for 6 months with a hydroquinone-based product if needed, and after that, transition to non-hydroquinone agents. So what non-hydroquinone agents can we consider? We have prescription and non-prescription cosmeceutical agents that have been shown to reduce hyperpigmentation. In the prescription category, we have topical retinoids, adapalene, tazarotene, tretinoin have all been shown to reduce hyperpigmentation. We have topical azelaic acid, which has also demonstrated reductions in hyperpigmentation at 15% and at 20% formulations. In the non-prescription area, we have a growing list of cosmeceutical agents that have active ingredients that may be helpful in reducing hyperpigmentation. And I present two more recent ones, including a multimodal compound called Litera 2.0, which we recently compared to 4% hydroquinone, and another novel agent called topical cysteamine 5% cream, which has been published in 2 randomized vehicle-controlled trials of melasma to be efficacious. So 2 new additions to our armamentarium that are non-hydroquinone based, and these fit nicely for long-term maintenance of hyperpigmentation or as adjuncts to hydroquinone when managing challenging hyperpigmentation such as melasma. Now, moving over to hypopigmentation, one of the common scenarios where we might see hypopigmentation in our practices is seborrheic dermatitis in patients of color. Patients with darker skin may present with hypopigmented patches in the typical seborrheic areas without much noticeable scale or erythema, and the hypopigmentation can be quite disfiguring to the patient. So managing that with several months of topical antifungal therapy or topical anti-inflammatory non-corticosteroid treatments such as topical pimecrolimus or other calcineurin inhibitors or topical crisaborole in conjunction with topical antifungals for a course of several months will result in resolution of the post-inflammatory hyperpigmentation associated with seborrheic dermatitis in this setting. Lastly, in hypopigmentation, I do talk about a condition that's often easy to miss. It's called progressive macular hypomelanosis, presenting with hypopigmented macules that can coalesce to patches on the trunk, especially the lower back and the abdomen. While there is a differential diagnosis, including tinea versicolor and hypopigmented mycosis fungoides, a useful tool to differentiate is the Woods light. The Woods light examination can reveal fluorescence at the follicular orifices of C. acnes, which is thought to be a causative agent, but it's involved in the pathogenesis of progressive macular hypomelanosis. So with respect to treatment, therapies directed at reducing C. acnes, such as clindamycin, benzoyl peroxide topically, as well as phototherapy in narrowband UVB in particular, are very useful for managing progressive macular hypomelanosis. Thank you.